Good afternoon. I am Dr. Gaurav Padia and I am presenting an interesting case of EUS. I hope my presentation justifies the title. 21-year-old male presented with acute severe necrotizing pancreatitis was managed conservatively. However, he developed a large symptomatic collection which was drained with a percutaneous drain at a peripheral center. Eventually, he developed a high output pancreatic fistula after a failed medical management. MRCP and CECT abdomen showed a disconnected pancreatic duct syndrome with complete disruption at the level of neck. ERCP was attempted and PD cannulation was tried but failed in spite of multiple attempts. On EUS, the tip of the drain can be seen at the level of neck. The pancreatic duct was identified in the body measuring 2.3 millimeter. Using a 19 gauge needle, the pancreatic duct was targeted and punctured. The tip of the needle can be seen in the pancreatic duct. Contrast was injected and a pancreatogram was obtained. Wire negotiation was attempted, but the needle accidentally got pulled out. Repuncture was made into the duct and wire was negotiated into the tail as confirmed on the fluoro. After securing the wire in pancreatic duct, the track was dilated using 6 French cystotome. However, the assembly got stuck due to shearing of the wire. In spite of repetitive attempts, we were not able to remove the wire and the assembly was buckling on itself. The whole assembly was removed and a blind re-entry using a cannula and a guide wire was attempted, and fortunately we could enter the PD and the wire was placed till the tail. A 5 French into 7 cm double pigtail was placed, confirmed on fluoro. After 8 weeks, the patient was completely asymptomatic with no drain in the external drain and no peripancreatic collection with stent in situ. The final diagnosis was acute severe necrotizing pancreatitis with unknown etiology with a large symptomatic collection and a disrupted duct in the neck region with high output refractory external pancreatic fistula. The case was managed by EUS guided retrograde pancreaticogastrostomy. The intra-procedural challenges were accidental pulling out of the needle from the duct during wire exchange, difficult repuncture and delineation of the duct, shearing of the guide wire making accessory exchange extremely difficult. The take-home message is, although surgical management is the first line in cases of disconnected pancreatic duct syndrome and complicated pancreatic necrosis, EUS-guided interventions can prove an effective rescue in difficult-to-treat surgically fit patients. Thank you.